And unlike the minister, I'll not subject this House to a lecture. However, I'll give a report of what it is, the reality of what it is. So, Right Honorable Speaker, while we join all Ugandans in thanking our dedicated frontline health workers who contain the clinical spread of this virus to just 20 cases, we must separate medical containment from administrative incompetence. The Ministry of Health may have managed the surveillance and clinical isolation very well, but its catastrophic failure in managing outbreak information has caused self-inflicted economic devastation that will take our country years back to recover from. This is the reality of the numbers, Right Honorable Speaker. There was no community spread. There was absolutely zero community transmission within the boundaries of Uganda. Looking at the anatomy of these 20 confirmed cases, the majority are DRC imports. Out of the 20 total cases, 15 were imported directly from the severe epidemic in the neighboring Democratic Republic of Congo. Then the remaining 5 cases were strictly secondary transmissions limited to medical frontline, like you told us here, frontline workers, and immediate family caregivers who are already under close monitoring. Right Honorable Speaker, this is and was not a Ugandan outbreak. It was a spillover from Democratic Republic of Congo. Yet because the ministry lacked a backbone of clarity in public communication, the world was allowed to believe that Ebola was tearing through our communities. They actually gave it a Ugandan face. So this is the cost of no clarity in communication, Right Honorable Speaker. Right Honorable Speaker, because the ministry has chosen an alarmist, uncoordinated approach to data dissemination, our premium of 1.7 billion US dollars of tourism sector was left exposed to international panic. The massive cancellation, Right Honorable Speaker, the ministry allowed international markets to believe the entire country was a hot zone. This triggered immediate booking cancellations during our peak May to September safari season. And then there's a liquidity crisis for local operators. Instead, this liquidity crisis for local operators terrified international clients, and this demanded immediate cash refunds, pushing local tourist operators to the brink of bankruptcy. And then the Namugongo wipeout. The Namugongo wipeout alone wiped out an estimate of 30 billion to 44 billion in domestic and regional trade. And this really, this hurt the local vendors and the transporters and the hospitality sector. Right Honorable Speaker, the halting of our progress. Uganda entered 2026 celebrating a 19.7 growth in tourism ban. The issue of the airport humiliation, Ugandans are being subjected to mandatory invasive secondary blood testing at airports. That's like in China and Dubai. Then there is the guilt of association, of course. While international health bodies lazily bundled Ugandan's single-digit data within massive 1,400 plus cases epidemic in DRC, the lack of data defense allowed foreign embassies to slap a blanket travel ban to Ugandans. Right Honorable Speaker, we propose these urgent reforms: an establishment of a joint inter-ministerial crisis communications task force, which should comprise the Ministry of Health, Ministry of Tourism, and the Uganda Tourism Board. We also request for an enforced aggressive data separation. The ministry must separate Ugandan tracking dashboards from neighboring countries. Then we also request for a proactive aviation and border diplomacy. And then a hyper-local non-alarmist reporting. In conclusion, Right Honorable Speaker, transparency is a legal obligation under international health regulations, but reckless communication is a choice. The Ministry of Health chose a path that protected their data charts, but destroyed Ugandan businesses and humiliated our citizens. We pray, therefore, for a formal, aggressive diplomatic push to lift the Dubai visa ban and airport blood tests in China. I beg to submit.
In the health sector, we operate a policy of openness. And the World Health Organization international standards require us to make a notification when we get these rare diseases like viral hemorrhagic fevers like Ebola. So professionally, it is not acceptable that you get this kind of illness and you keep quiet, because keeping quiet might result in other people getting infected. And that has been the policy in Uganda. You recall, Right Honorable Speaker, that even in the 80s, when the countries were fearing to say they have HIV and AIDS, President Yoweri Museveni authorized the then Minister of Health, Dr. Rakana Rugunda, to go to Geneva at the WHO Assembly and announced that Uganda has a big problem of HIV and AIDS. And other countries were laughing at us. How do you tell the world that you have this problem? But because of that openness, we were able to contain HIV and AIDS, and we are one of the countries that is on record for having successfully handled. But probably the advice you are giving is that while we should not hide information, but we should communicate in a manner that does not result in injuring our national economy and interests. Right Honorable Speaker, let me just explain one point, then I sit. Discharging the last patient does not mean that the country is Ebola disease free. The World Health Organization standards and recommendations is that when you discharge the last patient, then you start on a countdown. The incubation period of Ebola is 21 days, is up to 21 days. So we count 2 cycles of the incubation period. So we shall count starting today, 21 days plus 21 days, those are 42 days. So if in the 42 days we don't register any positive case, then Uganda will be declared Ebola free. What we have done, Right Honorable Speaker, is that our president talked to the president of DRC, and the 2 heads of state agreed that we handle this outbreak jointly at the 2 governments. And the 2 ministers of state signed an MOU. I signed on behalf of the government of Uganda, and my counterpart, Minister of Public Health in Congo, signed and agreed on a number of interventions to jointly pursue. One of them, which we agreed on, it's very important, I inform Parliament, is that this is an imported outbreak. It came into Uganda because Congolese were coming to Uganda for better medical care. So we agreed that the government of Uganda will support the Congolese government by establishing Ebola treatment centers on the other side of Congo. And the president authorized us to open up to 4 centers. We have so far opened one in Aru. Aru is the area which oversees West Nile. We have also opened one in Kasenyi, across in Toroko, Lake Albert. But we have also deployed experts in Bunya and Guampara, which is in the center of Ituri. So we have sent over 50 specialist health workers in Uganda to support our counterparts in Congo, and also agreed on joint surveillance, joint monitoring, sharing information. We have established a laboratory in Arua and Bwera and Kasese. Some of the samples from Congo are brought to our laboratories, but also we have Uganda Virus Research Institute and another one in Wandegeya. So we have joint collaborative activities. So although we now register 0 case in Uganda, but the collaborative interventions continue, and we shall work with Congo until they register the last
thank
case.
you, Right Honorable Speaker.
So like I have said, the case fatality rate means of those whom you tested positive, how many have died? We lost only 2, which translates to 10%. And for this strain of the virus, the case fatality rate usually ranges from 25 to 36%. That means we have done very well. We have not lost many of our patients. The other strains like Ebola Zaire is extremely virulent. It can kill up to 90% of those who test positive. But this one is a little less mild, but it can kill up to 25 to 36%. But this is an average. If it finds when you don't have a strong system in the country, it can also kill up to 90% or even beyond. So the fact that we've been able to have a low case fatality rate means our response system has been fairly effective. And even those who died, yes, you can clap for that. Even those who died, they died because they presented late. They presented late. And in the last 21 days, we have not registered any positive case. And in the management of Ebola, when a patient tests positive, then you trace back and get to the contacts. Anybody who has been in contact with that patient in the last 21 days, you round him up, or you bring him to isolation. And we did this. And through that system, we were able to identify 836 contacts who were in touch with these 20 cases that tested positive. We put them under isolation. They completed 21 days. None of them developed symptoms. None of them tested positive, and they have all been discharged. And that is a very important element in managing Ebola disease. Now, compare these results with what is happening across among our sisters and brothers in the DRC. I spoke to the officials. As of today, the 16th of July, they have 2,011 Congolese who have tested positive for Ebola. And they have lost 754 individuals due to Ebola. So in Congo, I was there a few days ago in Bunia, leading a team of Ministry of Health and WHO. I am very safe. I am very safe.
To thank the ministry so much for the work that you have done and how you have managed the disease. The clarification I want you, before you conclude, to raise, and that's why I came, is the issue of announcing that we have Ebola. Because when this disease comes and you're managing it very well, why does the information come out very fast that there is Ebola in Uganda? And when we travel, there is a ban everywhere. People start looking at you with scorn that you have Ebola. I want you to handle that particular matter when you are discussing, as you're concluding your statement, that particular area of announcing, and the Minister of Health announcing that there is Ebola in Uganda. Honourable members, this is a very important matter.
Honourable Minister, do you want to conclude? Do you really want to conclude?
Honourable Speaker, the communities along the border, DRC-Uganda border, we intensified the campaign and lots of interventions, which included closing markets, disallowing big assemblies of people. I have, for instance, received a petition from the bar owners in Arua and West Nile regarding the disruption of their business. Given the progress we have registered, we shall keep our borders with the DRC closed, but the National Task Force, chaired by Her Excellency the Vice President, will sit, and then we'll see how to flexibly allow people to return to normal situation. Number two, so we are handling those issues, especially on the border points. Number two, which is also very important, Right Honourable Speaker, is that what bothers Ugandans today are the travel restrictions and bans imposed by some countries, disallowing their citizens traveling to Uganda, but also making it difficult for people in Uganda to travel to their countries. Like I said, this is my last point. Just hold on, I allow you after I make the point. Right, Honorable Speaker, like I said, this Ebola disease was first identified in 1976. That means today it is 50 years old. 50 years old. We have had up to around 40 outbreaks in Africa, in Congo, in Uganda, South Sudan, West Africa. But the reported cases of Ebola that have been exported outside Africa are less than 30 in 50 years. Actually, to be exact, they are 29, including the recent case in France. So that means that Ebola, given its transmission dynamics, does not easily get exported outside. And even those 29 cases are mainly doctors and health workers who have been training. We are engaging the international community, especially the over 20 countries which have put those travel restrictions, that those decisions are not backed by science, because those decisions are hurting the economy, and Parliament should know. So we are engaging these countries, given the progress we have registered, with a view that they open up so that our economy doesn't get affected. I thank you very much.
And Bahamas are being subjected to mandatory quarantine. And now, what do you advise of other travelers who are likely to come from Uganda to travel to other countries? Because you have just told us you have given a window period of 42 days from now to declare Uganda a free Ebola country. 42 days, yes.
Honorable Minister, briefly, then since we are...
Honorable Speaker and Honorable Member, now, DRC, other than Uganda, is the only country with the outbreak. So if you enter Uganda and you have been in the DRC in the last 21 days, we quarantine you for 21 days, including the health workers who are there. When they get like leave and come back, we put them in isolation until when they complete. But if you are from the US, Kenya, anywhere else where there is no Ebola, there is no need for isolating you.
What is the order about, Honorable Namboze?
From DRC, the policy that the people who travel from Congo to Uganda are quarantined is in order to expose this house to Ebola by running out of the quarantine to come here. And in that spirit, as you rule, right, Honorable Speaker, isn't it proper that he also tells us how to deal with people who come from Congo, the Congolese who come to Uganda, and Ugandans like him who come from Congo? How should we treat them? I request that you rule on that. Is in order to be here when he should be in the quarantine, as he has told this house.
We quarantine somebody who has come from Congo is largely because we are not sure the kind of exposure you had when you were in Congo. Because you just arrive at the airport, say, where have you been in the last 21 days? You indicate I've been in Congo. In my case, the Minister of Health is sure that when I went to Congo, I was not in contact with any person who would pose a risk. Yes. Yeah, we are sure. The Minister of Health is sure that when I was in Congo, I never got exposed to the risk of Ebola. So that's why, so don't get worried. So nobody in this house,
thank you,
and even those who have met me in the last 21 days should not be worried about me being a risky person in terms of...
Thank you, that is clear.
Making you...
Shadow Minister of Health.